for Smarty to provide this opportunity to share our insight and our clear appliance of S8. And first, let me introduce myself. My name is Jiang, and I'm now working in Shanghai Taikang Bible Dental Hospital, one of the biggest clinic in Shanghai. And today, my topic is about a clear orthopedic approach called S8-SGTB in correcting severe jaw discrepancies. And first, I'd like to show you a picture of our team members. And this picture is about 20 years ago. Professor Shen was a vice professor in the University of Sydney. And this is the picture Professor Shen with his students in University of Sydney. And about 15 years ago, Professor Shen came back to Shanghai Jiao Tong University, and he became the Dean of Shanghai Jiao Tong University School of Stomatology. And now, we are now working in Taikang Bible Dental Hospital, one of the biggest clinic in Shanghai. And besides the clinical daily practice, we also have some collaboration with Smarty, one of the biggest clear aligner company in China, to do some innovative work. And before introducing the S8, I want to introduce a new diagnostic classification. So why we need to propose a new diagnostic classification? It's because we find that there are many shortcomings and pitfalls in conventional classifications, like the angle classification, which is focusing on dentition, and the skeletal classification, which is focusing on cephalometrics. But we find that there are huge differences between Western population and the Oriental population, so that the conventional classification cannot give us enough information to guide our treatment. So we face more severe jaw discrepancies, especially in facial prognatism. So Professor Shen finds we need a new and different diagnostic classification to guide our treatment. So he proposed a new diagnostic classification, which can take several elements into consideration. For example, the chief complaint, the accurate diagnosis, the complete materials, and the effective of treatment. And let us see two pictures of two patients' facial profile. They have some similarities. Both of them are protrusive profile, and they have protrusive lips, retrusive mandible, but they have some differences. For example, the first patient, his chin is deficient, but the second, the chin is prominent. So there are some differences. And when we take a look at the cephalometrics and the intraoral photos, we also can find some similarities. For example, they are both molar class 2, and they both of them have increased overjet, and they are all skeletal class 2. But also there are some differences. The biggest difference is that the shape or the morphology of the mandible is different. The first patient, his shape of the mandible is deficient, but the second, the shape is favorable. So, although they have same diagnosis, they are all skeletal class 2 and molar class 2. But actually they have different etiology and different treatment plan. The first patient, the etiology, why does this occlusion come from? It is because the condyle resorption, and it's a pathological reason. But the second patient, maybe it's because of physiological reason, it's because of the narrow upper arch, which force the mandible backward. So they have different etiology and they have different treatment plan. The first patient, maybe we should stabilize the TMJ first, and we should stabilize the mandible position. Then we can use the vertical control to intrude the molars and to correct the open bite. Besides, we can use extractions to retract the upper incisors and the lower incisors in order to get a better profile. But the second patient, we may not use extractions. Maybe we should advance the mandible. So they have different treatment plan. Let's look at this two cephalometrics. They have some same parameters, similar parameters. Their SNA degree, SNB degree, ANB degree, and FMA degrees are very close. But they are different. Their shape of the mandible is different, so they may have different treatment plan. The first patient may need to retraction, but the second, we may not retract. We may not extract the premolars. So they have similar parameters, but different diagnosis. So Professor Shen proposed a new classification of malocclusion based on facial assessment, not on dentition or cephalometrics. There are three major categories: the facial prognathism, the facial retrognathism, and the mandibular deviation. And among these categories, we highlight on the first one, facial prognathism, because this is the most common malocclusion in Oriental population or in China. So this is a new diagnostic classification system for malocclusions with prognathism. It is based on facial assessment first, and it also takes intraoral manifestations, malocclusion etiologies, mandibular position, TMJ conditions, and the treatment modalities into consideration. And this picture is the classification for malocclusion with facial prognathism. I'll have a brief introduction of this classification. They are called fundamental dental alveolar, fundamental skeletal, mandibular retrusion combined with dental alveolar, mandibular retrusion combined with skeletal subtype 1, mandibular retrusion combined with skeletal subtype 2. So what does it mean? Or what? Let's have a description. The first is fundamental dental alveolar. So there is no skeletal problem in this category. The jaw morphology is favorable and the jaw position is okay. So there is no skeletal problem in this patient. And the manifestation is that they have proclined upper incisors, and maybe it comes from bad habit or airway problems. So how to deal with this kind of problem? It's easy. Just create space, like extraction or distalization or expansion. We just need space to retract the frontal teeth. And then we should withdraw the bad habit or solve or address the airway problem. Then it is solved. The second category, fundamental skeletal. It means that there is overgrowth of maxilla and there is a deficient morphology of the mandible. It means that the shape of the mandible is not favorable. We call it triangle shape. It means that there is a deficiency in morphology of the mandible, but the position of the mandible is correct. So the intraoral photo, we can see there is a class 1 molar relationship and the overbite and overjet is normal. So how to deal with this kind of problem? We may use extractions or we can use vertical control in order to control rotate the mandible, but there is a high demand on anchorage control and torque control and vertical control. And we should notice that this kind of patients are susceptible to TMD or condyle resorption. And we want to emphasize on the last three categories, which are called mandibular retrusion categories. They have similarities. They are all, in intraoral photos, we can see they are all deep over bite, deep over jet, and deep curve of spee. And their shape of the mandible is favorable. We call it flat and rectangular, compared to fundamental skeletal, which is a triangle shape of the mandible. So the shape or the morphology of the mandible in these three categories are favorable. And they have some differences in the upper. The first category, mandibular retrusion combined with dental alveolar, the upper, there is no overgrowth of maxilla, but there is proclined incisors. But the mandibular retrusion combined with skeletal, there is overgrowth of maxilla, and the upper incisors are straight. And the mandibular retrusion combined with skeletal too, the upper is overgrowth. The upper maxilla is overgrowth, but the upper incisors are retroclined. So they have so many same manifestations. We call these three kind of categories 3-deep problem. And it's really hard to solve, especially the mandibular retrusion combined with skeletal. But we have different treatment plans for each categories. Especially for mandibular retrusion categories, we have a new clear appliance called S8-SGTB, which is specialized to treat this kind of malocclusion. And before that, we can see this is a summary of all the different aligners of Smarty solution from S1 to S17, including mandibular repositioning device and the invisible forward traction device and the palatal device. And among that, the most important one is S8, which is mandibular repositioning device, or we call it mandibular advancement. So this is a picture of S8-SGTB. Actually, it is an improvement of twin block, and it is a combination of clear aligners and the twin block. So let's have an overview of today's lecture. We want to answer three questions: what, how, and why. So what is S8-SGTB, and what is the indication of S8-SGTB? And second, the question is how to use S8-SGTB. Okay, and these are two photos of S8-SGTB intraoral and the vivo picture. It is a combination of clear aligners and orthopedic appliance, and it has so many advantages. For example, it is comfortable, and it is small in size, and it is clear version, and it is more adult acceptable. And also the biggest advantage is that it can do teeth movement. So let's talk about the advantage of S8. It is a combination of clear aligner and orthopedic appliance, twin block. And it is comfortable, and it is small in size, and it is clear version. Also, it is adult acceptable. So the biggest advantage is that we can do teeth movement together with advancement of the mandible. So there is no phase 1 and phase 2. They are totally merged. So this is the biggest advantage. And the second, what is the indications of S8? Let's see several cases. They have some same manifestations. We can see that the overbite and overjet is quite increased, and the molar relationships is class 2. And we can see the facial profile. It is he has protrusive lips and a retrusive mandible. And the second patient also increased overjet, increased overbite, increased deep curve of speed, and also molar class 2. And we can see retrusive mandible. Third patient, increased overjet, increased overbite, deep curve of speed, and full unit class 2, and also a retrusive mandible. So we can have a conclusion. Do they have some similar manifestations? Yes, they have protrusive facial profile. They have retrusive mandible. They are all class 2 molar relationships, and they all have deep overjet, deep overbite, and deep curve of speed. So these are the similarities of this patient. This is group 1. They are all severe jaw discrepancies. And we can see group 2 patient. They have deep overbite, deep curve of speed, and molar class 2. Deep overbite, deep curve of speed, molar class 2. And of course, retrusive mandible. Deep overbite, deep curve of speed, retrusive mandible, molar class 2. And group 2 patients, they are all mandibular retrusion, and they all have class 2 molar relationships. They are all deep overbite, deep curve of speed, and actually they have deep overjet, but they are hidden behind the retroclined upper incisors. So they are also severe jaw discrepancies. So how to treat these two groups of patients? Do you have any idea? The first choice is molar distalization, the upper molar distalization. But is there any problems? Yes, we find that distalization is not that effective enough because we need a lot of distance of distalization. And the difficulty is how to retract the space created by the distalization. And it's really hard to retract the upper incisors in such a large amount or such a long distance. And we cannot retract the upper incisors to match the occlusion with the retrusive mandible. So this is the first choice, distalization. It's really hard. What about extraction? Extractions of upper premolars, we can have more space to retract, but also it's difficult to flatten the deep curve of speed, and it's difficult to retract upper frontal teeth because of the torque control and the anchorage control, and also the boundary of the cortical bone. And there is high risk of root resorption and condyle resorption if we need to retract such a long distance of the upper incisors. And also it can be a damage to facial profile, especially for young ladies. So what about surgery? Can we use surgery to solve these problems? It might be a choice, but we should know that there is a balance between the benefit and cost. Many patients, they cannot accept surgery. So it seems that we don't have a good way to treat these three deep problems or this kind of jaw discrepancies. So what about mandible advancement or mandible repositioning? So we know that in textbook, it is allowed to do it for children, but not for adults. But we try a lot in adults, and it's a great success. So this is the S8 in place. We can see it can convert the molar class 2 into molar class 1 and to correct the overbite and overjet. And let's take a look at the S8 in place. We can see that this 3 deep malocclusion, when S8 take place, the overbite and overjet is exposed. And after 10 months of constant reposition of the mandible, it can get a new and stable position. And at the same time, we can do what? We can intrude the incisors, we can expand the premolars, the dental arch, and we can do alignment. And then we can correct the severe deep overbite and overjet. Also, the profile improved. And we can solve a lot of problems. For example, this case, we can use S8 to correct the severe jaw discrepancy. And this, we can see that deep overbite is easily solved by S8. And this, a severe overbite, is solved by S8. So we have a conclusion. So what is the indication of S8? Mandibular retrusion, class 2 molar relationships, deep overjet, deep overbite, and deep curve of speed. When they take place together, it means that there is a retrusive mandible. It means that the morphology of the mandible is good, but the position of the mandible is retrusive. So this time we can use S8-SGTB. So how to use Smarty S8? How to use it? We should know that we also divide it into 2 parts, phase 1 and phase 2. In phase 1, we have orthopedics and orthodontics together. Although the priority is the mandibular reposition, we can also align the teeth, especially molar distalization, dental arch expansion, flattening of the curve of speed, and the teeth alignment. And takes about 10 months because we need a 10 months constant mandible reposition in order to have a stable position, new position. We emphasize that we should wear it 7/24, 7 days a week, 24 hours a day, even when eating. And in phase 2, it is only the orthodontic work. We should do interdigitation, deliberation. We should build the intercuspation. We should flatten the curve of speed. Also, we can do other teeth movement. It's okay. And let's see 2 cases. The first case, a 28-year-old female who has protrusive lips and retrusive chin with dental crowding. We can see that incompetent lips and the facial profile, protrusive lips and retrusive mandible. And intraoral, we can see 3 deep overbite, deep overjet, and deep curve of speed. The molar relationship is full unit class 2. And we can see there is condyle resorption. There is a symmetry in condyle. So, is it the indication of S8? Yes, it is mandibular retrusion. It is class 2 molar relationships. It is 3 deep overjet, deep overbite, deep curve of speed. So it is an indication of S8. So this is our treatment plan. We have phase 1. What we should do, the priority is mandibular repositioning, and also we should do alignment, dental arch expansion, molar distalization, and leveling the curve of speed. And there are some specific questions. For example, what is the ideal jaw position? How to create the space? How much do we need to expand? And how can we get the anchorage for molar distalization? How to leveling the curve of speed? These are some specific questions. And this is the answer. What is the ideal jaw position, or what is a new position we should get? I think it is a molar class 2 tendency position. Why molar class 2 tendency? Because we need some retraction of the upper incisors. So we don't need to advance the mandible to very class 1. We can advance the mandible to a class 2 tendency, and then we can, same time, we can retract the upper incisors in order to have a correct overjet and overbite. How to create space? Of course, expansion and distalization, and we should do both arch expansion in order to create space. And we should do upper molar distalization in order to create space for upper incisor retraction. And also we should do lower incisor intrusion and uprighting the lower molars in order to leveling the curve of speed. And we can see this is the treatment plan. We can see we are doing upper expansion, upper molar distalization, lower incisor intrusion. At the same time, reposition the mandible. And this is the first month of phase 1. And this is the 10 months of phase 1, the phase 1 finish. After 10 months of mandibular repositioning treatment, the mandible could not move backward and can stay in this forward position steadily. And we can see that the retrusive of the mandible is improved. And in phase 2, what should we do? We should leveling the curve of speed. We should do dental arch coordination. We should build the intercuspation, and we should retract the upper frontal teeth. And we can see the phase 2 plan. It's not difficult. With the help of micro-implant anchorage, we retract the upper incisors, and also we flatten the lower curve of speed. And we can see that after 4 months of phase 2, the intercuspation is built, and we can see a class 1 molar relationship. And finally, we get a perfect molar relationship and a perfect overbite and overjet. We can see that there is a big change of overjet, overbite, and molar relationship. What about facial profile? It is also improved quite a lot. And we can see that the mandible is advanced to a forward position. Let's see, look at a second case, a 23-year-old male. We can see that the facial profile, the retrusive mandible is very prominent, and we can see that the upper is not very protrusive. But the intraoral, we can see that deep overbite, deep overjet, and deep curve of speed. Also, the morphology of the mandible is very favorable, and we can see the retrusive position of the mandible. Is it the indication of S8, mandibular retrusion, class 2 molar relationship, deep overjet, deep overbite, and deep curve of speed? It is a perfect indication of S8. So the treatment is similar to case 1. We do mandibular reposition At the same time, align the teeth, expand the dental arch, distalize the molar, and level the curve of speed. We can see the phase 1 treatment plan. We are intruding the lower incisors, expanding the upper dental arch, and distalize the upper molars at the same time. S8 in place. And about 9 months of phase 1 treatment, we can see that the mandible is stable in a new position. And at this time, the molar area is open bite. But don't worry. The phase 2, we should further leveling the curve of speed, and we should do dental arch coordination. And also, we should crack the midline and build the intercuspation. The priority is leveling the curve of speed and the intercuspation. And we can see how to build the intercuspation. We intrude the lower incisors and extrude the molars simultaneously. Why can we do that? Why don't we need a stage to intrude the incisor first and then extrude the molars? Why do we don't need that? Because we have a new position of the mandible and the deep curve of speed is fully exposed to us, and there is no biting force in molar areas. So actually we can do incisor intrusions and molar extrusions at the same time. So about 3 months, the intercuspation is nearly built and finished. We can see that a perfect class 1 molar relationship and the overbite and overjet are corrected. And also the facial profile, we can see that the retrusive mandible is improved. And let's take a look at the cephalometrics. The mandible position is changed. And we can see that the mandible advancement. And we have a 2-year follow-up. We can see it's still stable. So let's go to the final question. Why could we get a long-term stable forward position of the mandible? So let's take a look at the CBCT inspection of condyle. We can see that there are some differences in these 4 photos. They are taking initial, the finish in the end of the phase 1, end of the phase 2, and the finish. We can see that the shape of the condyle is changing. We can see that there are 2 outlines of the cortical bone of the condyle. This is amazing. It means that the condyle is restoring. This is a restoration of the condyle. And also we can see that the space in TMJ is readapting. So the condyle is reaccommodating. They are finding a best location. So the space between the TMJ and condyle is actually changing and readapting. This is the left side. We can see 2 outline of the condyle, which means the newly formed bone of the condyle. And the space is changing. The condyle is reaccommodating, and the TMJ is remodeling. So, do we have any evidence, radiographic evidence of TMJ remodeling with S8-SGTB therapy? Yes, we have a lot of evidence, especially in adults. We have CBCT inspection. We see a lot of evidence of double outline of the condyle. we can see that there is a defect before the treatment of the condyle, and it is restored, and the space is changing. We have MRI inspections. We can see more clearly in MRI inspections. You can see the newly formed condyle bone. So actually we have so many studies on this project about 20 years ago. We find that the cartilage in condyle is different from the long bone. It has a very amazing characteristic, which is a lifelong remodeling ability. So this is very critical or very crucial for our TMJ remodeling treatment, especially for the mandibular advancement treatment. So we have some article on AJODO of SGTB in correcting 3D problems patients in adults. So this is why it can work, and it can get a very stable position of the mandible. So let's have a conclusion of today's lecture. We share a clear orthopedic approach called S8-SGTB in correcting severe jaw discrepancies. It is a clear version mandibular repositioning treatment. It can reposition the mandible first and at the same time align the teeth. So actually it is a combination of orthodontics and orthopedics. And it can advance the mandible continuously. It can lead to the TMJ remodeling, and it requires 7/24 varying. And there are so many advantages of Smarty S8. It can reposition the mandible and can correcting malocclusions simultaneously. It can correct severe class 2 jaw discrepancy and minimize the need for surgery and extraction. And it is a promising treatment efficacy in adult patients. And we have over 30,000 S8-SGTB cases in China now. And this is Professor Shen and his story with Smarty GS. And thanks for listening. Thanks so much.